Hi, everyone. We're going to give people a few minutes to come on, maybe about 2 or 3 minutes, then we'll start. Okay, we're just going to give it about another 1 or 2 more minutes before we begin. Okay, give it 1 more minute. Okay, we got about 30 seconds left before we start to allow everyone to come back in or come in. Okay, so I'm going to get started. My name is Jordan Karlitz. I'm the Director of Clinical Operations for GI On Demand. And this webinar is titled Integrating Genetics into Your GI Practice to Identify Hereditary Cancer Syndromes. And 2 other speakers are going to be Heather Hampel, who's the Senior Director of Genetic Services at GI On Demand, and Kory Jasperson, who is the Director of Clinical Services at Ambry Genetics. Just some basic issues. Everyone's muted, so if you have any questions, please type them in the question section, and also be aware that this is being recorded so that people miss anything, they could go back and look at it. Okay, next slide, please. Okay, advance. Okay, so in terms of GI genetics, which is obviously the focus of this webinar, there are 2 ways to think about this. There are patients with cancer, and then there's patients with a family history of cancer. So in terms of patients with cancer, there are many types of GI cancers, including colorectal cancer, gastric cancer, pancreatic cancer, etc., that may harbor underlying mutations. Unfortunately, most of these patients go unrecognized, and this clearly will place patients and even their family members at great risk. Importantly, there are about 150,000 cases of colorectal cancer in the US alone each year. And surprisingly, well, not surprisingly, I think a lot of people don't realize this, but up to 10% can be hereditary. So you're talking about a major public health issue in terms of not identifying hereditary cancer syndromes. Next slide, please. In terms of GI cancers with regard to family history, there are many patients without a personal history of cancer, but that have a strong family history of cancer that may require genetic testing. Most of these patients and family members go unrecognized, and similar to patients who actually have a history of cancer, it places both the patient and their family members at significant risk. Importantly, 1 in 279 people in the United States harbor a Lynch Syndrome mutation, and most are completely unaware that they're carriers of this mutation or one of these types of mutations. And that accounts for about over 1 million people in the United States. Next slide, please. So I do want to talk about some testing deficiency studies that we recently published in ACG journals. Just to give you an idea of some of the barriers to genetic testing that we're facing. The first is a study that I participated in that was published in the Red Journal in 2015 that was entitled Population-Based Lynch Syndrome Screening by MSI Testing in Patients 50 and Under, Prevalence, Testing Determinants, and Result Availability Prior to Colonic Surgery. So this study really focused on underutilization of Lynch syndrome screening with tumor testing, so microsatellite instability testing or immunohistochemistry testing. But I think you could extrapolate these results to germline genetic testing as well. Next slide, please. So in this study, we looked specifically at Lynch syndrome, which is the most common hereditary colorectal cancer syndrome. Advance, please. And this was really the first population-based study in the United States examining Lynch syndrome screening practices. And what we did is we looked at all patients 50 and under in Louisiana diagnosed with colorectal cancer using CDC-funded comparative effectiveness research data. We had 274 patients, pretty much every single patient in the state at any healthcare facility during this one particular year. The data included testing on colonoscopy biopsy specimens, but also on surgical resection specimens as well. And what we found, really the punchline here, is that the overall Lynch syndrome screening rate with MSI and or IHC testing on colorectal cancer tissue specimens was only 23%. So you're talking about a very young patient population, and clearly even back a few years ago, that testing rate should have been 100%. So much lower than what it should have been. Next slide, please. And when we actually when we kind of delved into this a little bit more deeply and looked at different variables, we found that if you were receiving care at a public hospital, your testing rate for Lynch syndrome was only 6.5%. And even if you had a first-degree relative with colorectal cancer, still only 48% of those patients were tested with MSI and or IHC. And if you did not have a family history of colorectal cancer, your testing rate was only 23.6%. So you can see that these testing rates are far from optimal. Next slide, please. Previous slide.
Oops, sorry.
We did look at some other variables, including geographic variation, and there were certain regions in Louisiana where testing rates were higher or lower. But really, I think the most important take-home on this slide is that if you lived in a rural area, your tumor testing rate to screen for Lynch syndrome was only 12.3%. Next slide, please. So based on these results, we wanted to really delve in further and try and figure out why these testing rates were so low. So what we ended up doing is we did a national survey of ACG member gastroenterologists in 2018 that we published in Clinical and Translational Gastroenterology. And the main point of this study was to figure out what the barriers to genetic testing were in Lynch syndrome. I should mention that a lot of the questions in this survey focused on tumor testing, so microsatellite instability testing or IHC testing, but we did also ask questions about germline genetic testing. Next slide, please. So really the take-home points in this survey were that we identified a number of barriers to test ordering. One of the first, or one of the most important, was perceived cost of testing. So 33.3% of gastroenterologists felt that cost may be an impediment to ordering testing. Another key issue was unfamiliarity interpreting results. So 29.2% of GI doctors reported this as a barrier. And importantly, about 25% said that 25% of survey respondents said that they had unavailable genetic counseling in their communities, which is why it's so important that we're having this webinar today, in which we're going to describe how we can implement genetic counseling services in any practice in the United States. Importantly, non-academic and rural settings were associated with cost and genetic counseling barriers. And you could see this theme with rural settings that was also seen in the Red Journal study. Next slide, please. This is an important slide because we actually asked GI doctors who they felt should order tumor testing. And you could see here that when you ask GI doctors who should order the testing, they felt that it should be the pathologist most of the time. So 38.6% of gastroenterologists said it was the pathologist who should be ordering it. 33.4% of GI doctors felt that they themselves should be ordering it, but you could also see that there are a number of other provider types that GI doctors felt should be ordering the testing. So again, this is tumor testing. So I think the real issue here is what's called diffusion of responsibility. So what this means is that one provider type thinks another provider type is ordering testing, and that other provider type thinks the other provider type is ordering the testing. So this is kind of a classic case of diffusion of responsibility. And I think the same is likely going to apply to germline genetic testing ordering as well, where one group of providers may think the other group is responsible, and then it just never gets done. Next slide, please. So themes from these studies, Lynch syndrome testing rates, whether they're tumor testing or germline testing, are clearly far from optimal. And then although testing deficiencies are present in all settings, a lot of these deficiencies or barriers really tend to cluster in underserved communities and rural areas. So that should really be one of our main targets to enhance genetic analysis. Key testing barriers include a lack of access to genetic counseling, again, especially in non-academic and rural settings, and importantly, unfamiliarity interpreting test results, which clearly a genetic counselor could help with, and even perceived cost are important barriers to testing. Next slide. So really the goal for us in developing this GI on Demand and Ambry partnership was to use these objective data to create a tailored genetic testing tool to ensure tertiary care level genomic services are available to all GI providers in any location, really anywhere in the country. So this can include underserved communities, rural areas, and it can include any type of GI practice setting, so single specialty practices, multi-specialty practices, and even academic centers that may not have readily available genomic resources. One more advance. And importantly, a virtual platform, like we're going to get into the details of. The virtual modality for this could really circumvent delays in care if patients are going to be evaluated in person. So the virtual care platform could alleviate issues with travel distances, travel cost, time off from work, et cetera, that may be required for in-person visits. So now I'm going to turn it over to Heather Hampel, who's the Director for Genetic Services for GI On Demand.
Thanks, Jordan. I'm so happy to be here tonight. Just transferring the slides over really quickly, and then we'll get started.
Just a second.
While we're doing this, what I'm going to talk about in the next portion of the talk is how common these hereditary cancer syndromes are in your GI patient population, just to give you a sense of how many patients you're seeing every day who have one of these hereditary cancer syndromes. And it's really timely that we're doing this today because today is actually Lynch Syndrome Awareness Day. So really good timing on our webinar. The other thing I just wanted to remind you all at this point in the talk is I'm sure you've already got questions from Jordan. You're going to have questions from my portion and Kory's as well. If you can enter them into the questions portion on the screen, we'll be taking as many of those as we have time for at the end. Okay, so here we go. Basically, you guys know genetics is complex and changing rapidly, which can make this hard to keep up with. For example, the NCCN criteria, which determine who needs to be referred for a hereditary GI cancer evaluation, and they also have guidelines for hereditary breast, ovarian, prostate, and pancreatic cancer evaluation, change at least once a year, if not more than that. So it's very hard to keep up on this. We also are aware that access to genetic counseling can be challenging in some areas of the country where there aren't as many genetic counselors and patients have to travel. Although COVID has taught us that Televideo is a nice solution for that and hopefully is opening up access for many of your patients to genetic counseling. There are risk assessment tools in use currently in many clinics, and you obviously can continue to use those. We encourage that, but a lot of them only address a personal or family history of colon cancer and or polyps, which can miss a lot of hereditary cancer syndromes. And so, we keep hearing this need for some kind of comprehensive solution to collect family history consistently, perform a risk assessment using the most up-to-date criteria to determine which of your patients need genetic services, offer them that genetic testing, and receive tailored management guidelines. And then, of course, make sure that the patients have access to genetic counseling if they test positive or if they need it, so that everything can be explained in a way that they understand. So we are going to start by talking a little bit about the most common hereditary GI cancer syndrome today, and that's Lynch syndrome. So this is the most common inherited cause of both colorectal and endometrial cancer. And that's, again, why we have to ask about cancers other than just the colon. It also causes increased risk for gastric and ovarian cancer. And it's extremely common. Over 1.2 million individuals in the US have Lynch syndrome. It's estimated that 1 out of every 279 individuals has Lynch syndrome. And it's 1 out of every 25 individuals with colorectal cancer. As I mentioned, it causes increased risk for colon, endometrial, stomach, ovarian, and many other cancers. But they're pretty preventable as long as we do earlier and more frequent surveillance. So the problem is that current estimates are that 90 to 95% of individuals with Lynch syndrome are not aware of their diagnosis. So they are not able to benefit from these potentially life-saving procedures and prevention and screening options. Here are the cancer risks for an individual with Lynch syndrome to age 80, and it depends on whether their underlying pathogenic variant is in one of the high-risk genes, MLH1 and MSH2, where the risk of colon cancer can be 33 to 61% compared to 4.2 in the general public by age 80, or in the lower risk genes, MSH6 and PMS2, where the risk ranges somewhere from 9 to 44% by age 80. Any way you slice it, significantly increased risk. The endometrial cancer risk, 4 to 38% in the high-risk genes, can be quite as high in the low-risk genes, 13 to 49%, compared to 3% in the general public. Stomach cancer, lower, but elevated, and ovarian cancer, as high as 24% with the high-risk genes, which is almost as high as the ovarian cancer risk with the BRCA2 gene, although people don't tend to think of Lynch syndrome when they have an ovarian cancer patient or family history. Sorry, the slide seems to want to advance on its own tonight. The surveillance options. So this is how you all are managing these Lynch syndrome patients. So individuals with Lynch syndrome need colonoscopy every 1 to 2 years. For those with the high-risk gene mutations, MLH1 and MSH2, that starts at age 20 to 25. For your patients who have MSH6 or PMS2 pathogenic variants, that starts at age 30 to 35. But this is obviously significantly more frequent than someone in the general population who may start at 45 or 50 and go every 10 years, having a total of maybe 4 colonoscopies in their lifetime. An individual with Lynch syndrome could have 50 colonoscopies or more during their lifetime. And it's very important that you identify these patients so that they are getting this surveillance. They have a very fast adenoma to adenocarcinoma sequence. The average dwell time is only 3 years, so they have to have much more frequent colonoscopy. And then, of course, there's surveillance for the gynecologic cancers, including that many women who have Lynch syndrome elect to have a risk-reducing hysterectomy after childbearing. Some other GI screening includes EGD for people who have a family history of stomach cancer or any risk factors like mutations in the high-risk genes, family history of gastric cancer, Asian ethnicity, or some other conditions like gastritis or metaplasia or H. pylori that could increase their risk. So these patients are going to need a lot of intensive surveillance in the GI clinic, suffice to say. So how did we identify patients with Lynch syndrome in the past? We had to really rely on family history, which we still do on a great extent, but we have had multiple different criteria over the years, including the Amsterdam criteria, which most people remember by the 3-2-1 rule. So 3 cases of Lynch syndrome cancers in the family in at least 2 generations. And one of the individuals has to be diagnosed under age 50. The other one is that one of the affected individuals does need to be a close relative of the other 2, just giving you that feeling that there's like an autosomal dominant inheritance pattern in the family. That criteria has been shown to be a little bit too strict, and not all patients with Lynch syndrome meet the criteria, and some patients who meet that criteria don't in fact have Lynch syndrome. So there were the looser criteria, the Bethesda criteria created that were originally actually to identify which patients needed tumor screening to see if they were more or less likely to have Lynch syndrome, but they've kind of been used as sort of a looser criteria for referral for genetics. And that includes an early onset colon cancer diagnosed under age 50, 3 cases total of Lynch syndrome cancers in a family at any age, or 2 cases if one's under 50. And then finally, there's some very nice online models, which you may use in your clinic. For example, the PREM5 model. You'll see the URL here. I literally just Google PREM5 whenever I want to use this in my clinic, and it's a very quick screener that asks you a series of questions about a patient's family, and then it tells you the % likelihood that they have a pathogenic variant in a Lynch syndrome gene. And anyone that has a 2.5% or higher likelihood of having a pathogenic variant in a Lynch syndrome gene warrants referral to cancer genetics. So these are ways that you can use still to identify patients with Lynch syndrome. Of course, I spend a lot of my research time working on tumor screening for Lynch syndrome, but that's not what we will be talking about tonight. This is another tool that is used in clinic. This is the U.S. Multi-Society Task Force approved family history screening tool from FACG. And it's just a 3-question tool where individuals are asked a series of yes or no questions. If they answer yes to any of them, they warrant referral to cancer genetics. Again, you'll see they're very colon specific, which does a good job at identifying patients with Lynch syndrome, but might miss a lot of other hereditary cancer syndromes. So let's talk about how often you might find a hereditary cancer syndrome in your patient population. So let's start with your patients who have colon cancer. So there's a nice paper by Matt Yergelin and the Dana-Farber group where they tested over 1,000 individuals with colorectal cancer, and they used a nice multi-gene panel test. So these are the panels we typically order in cancer genetics clinics now, and the testing has improved dramatically in the past 5 years or so, and so we can get these multi-gene panel tests for rather inexpensive cost. So usually most patients actually are covered and own very little or less than $100. And if the patient doesn't have good coverage, there are patient pay options at most of the laboratories with an out-of-pocket max of $250. So this is something that's become much more accessible for patients regardless of their insurance coverage. And we can do a panel of genes for less cost than it used to be just to do the Lynch syndrome genes. So these patients were tested for a panel of 25 common hereditary cancer genes, and they were not selected based on their age of diagnosis or family history. And it was found that 10%, 9.9%, had a pathogenic mutation in one of those 25 genes. Okay, the most common syndrome, as expected, was Lynch syndrome at 3.1%. But the surprise was the 7% that had pathogenic variants in non-Lynch syndrome genes. So these are things that might not be picked up with those family history screening tools that we just talked about. This included 2.2% that had mutations in high penetrance genes. There's a polyposis, some polyposis there. Biallelic mut YH is going to be polyposis as well. Look at all these BRCA1 and 2 mutations, 11 of them. That has not been associated with colon cancer, but that's certainly very important for this patient and their family member who have very high risk for breast, ovarian, prostate, and pancreatic cancer. PALB2, similar gene with similar risk as BRCA2. A CDKN2A gene mutation, that's a melanoma pancreatic cancer gene, and those patients need increased surveillance for pancreatic cancer. And one TP53 germline mutation, that's Li-Fraumeni syndrome, which is a very significant high-risk syndrome causing increased risk for lots of cancers, including colorectal. 3.6% had mutations in what we would consider moderate risk colon cancer genes. So 19 of these people were carriers of mut YH mutations who have essentially twice the risk of colon cancer as someone without a mut YH gene mutation. So it essentially makes their risk the same as having a first-degree relative with colon cancer. 17 had the common Ashkenazi Jewish APC mutation, which again doubles the risk of colon cancer. So it's akin to having a first-degree relative. So these individuals, you know, start at 40 instead of 50, and they go every 5 years instead of every 10. And these two CHEK2 mutations, CHEK2 is a moderate risk breast colon gene. So again, these are the kinds of things that you might miss on our typical screening tool, but are rather important for that patient and their family, and they are actionable. And importantly, age of diagnosis, family history of colon cancer, or personal history of other cancers did not predict the presence of mutations in non-Lynch syndrome genes. Okay, next slide. We're going to talk about your young colon cancer patients. So this is one of my research studies out of Ohio State, where we tested 450 individuals diagnosed with colon cancer under age 50. So obviously they're going to have a higher rate of testing positive than the last study we just saw, which was all comers. So if you look at your young patients, you're up to a 16% chance that they're going to test positive. Half had Lynch syndrome, as expected. Half had mutations in other cancer susceptibility genes, and you see the pie chart over here, and it includes a similar portion of some high penetrance colon genes, some moderate penetrance colon genes, and then some genes that have not traditionally been associated with colon cancer but are very important for that patient and their management. And as a result, you know, of this and other studies, the NCCN does recommend genetic counseling and testing to all of your colorectal cancer patients who are diagnosed under age 50, regardless of their family history. Let's talk about your polyposis patients for a minute. If you look at your polyposis patients, this is a research study we actually did with Kory, who'll be talking in a minute, looking at tests performed at Ambry Genetics and what the reported polyp history was in the individual. We also looked by age of diagnosis, because we had this idea that, you know, 20 polyps at age 70 was probably not as concerning as 20 polyps at age 20. And it turns out that is true. You are less likely to test positive if you have 20 polyps at age 70 than if you have 20 polyps at age 20. You see in the middle graph there, it goes from a 54% chance of testing positive, 53.6, down to a 7.1%. But we were kind of surprised that it never went below 5%. Even in the category of patients who only had 10 to 19 polyps and were in their 70s, they still had a 5.3% chance of testing positive for one of a panel of genes, including polyposis genes, Lynch syndrome genes, and other cancer susceptibility genes. So we were surprised that we didn't find, while it did decrease, it never went below 5%. So we still agree with the recommendation that any patient with more than 10 adenomas should be seen in cancer genetics and have an evaluation and probably testing because they have a high enough chance of testing positive, and that can significantly change their management and help their family members identify when they need to start screening, et cetera. Here is a new paper, fresh off the press, from the Mayo Clinic and Jules Samatter, a gastroenterologist there. And this is a study where they offered germline genetic testing to every solid tumor cancer patient being seen at their institution, all of the sites, over a couple-year period. And these are the results for the GI cancers that I have boxed in red for you. And down below, I pulled the numbers so you didn't have to add up the little bars. But essentially, this is, again, is all comers with solid tumors at the Mayo Clinic. And they did a large panel of genes, more than 25, which is why you're seeing higher percents here than we saw before in the Jurgelin study. But essentially, 15% of their colon cancer patients tested positive on the panel, 16% of their pancreatic cancer patients, small n, but 25% of their small bowel cancer patients tested positive. 15% of their esophageal or gastric cancer patients tested positive, 16% of hepatocellular, biliary at 14%. Is very consistent, really, around that 15% number, which is certainly higher than we thought it would be. And you can see the different genes outlined across the top, but it's really a multi-gene panel to pick up all of the common hereditary cancer genes. And so we had been thinking at GI On Demand how we could maybe help gastroenterologists come up with a consistent way of getting family history, using those NCCN guidelines, having the most up-to-date ones, and offering testing and counseling to your patients kind of in a one-step solution. And that is why we would like to announce this partnership between GI OnDemand and Ambry Genetics. And I'm going to turn things over to Kory Jasperson, a good friend of mine and collaborator from Ambry Genetics, who's going to describe this care platform to you guys in more detail and how it really kind of from nuts to bolts is kind of a seamless way to integrate family history taking, risk assessment, genetic testing, and genetic counseling into your practice. And we hope it will be helpful for many of you. So I am now just going to, okay.
Thank you, Heather. I don't see it popping up on the screen yet.
Yep, sorry, working on that. Okay, Kory, I'm turning it over to you now.
All right, thank you much. All right, I believe my slide should be showing now. Thank you, Heather. Thank you, Dr. Karlitz, for going over a great background on genetics and GI practices. Before I kind of go into the care program, I wanted to highlight a few things about barriers to implementing genetics into GI practices or into general practices overall. Dr. Karlitz had kind of gone over a number of the barriers providers might have, such as maybe they're not comfortable with disclosing certain types of results to patients. Additionally, maybe they have concerns about the cost of genetic testing. There's a number of different provider barriers we should all think about. Could also be maybe they aren't comfortable actually even implementing an identification tool, or they don't have the resources to really talk to their patients, spend the time to test them while they're in clinic. But we also have to think about patient barriers as well. So if we solve a solution for only one of the groups, maybe we make it really seamless for providers to implement genetics, but we don't address any of the patient barriers, ultimately the patients won't get tested, and vice versa. We could make a really seamless process for patients, but if the providers can't implement genetics into their practice or can't offer the testing, then the patients still won't end up getting testing. So the basis of the care program was really trying to think about the many different barriers both providers and patients experience in either getting genetic testing, genetic counseling, or in integrating genetics into their practice. So we really kind of thought long and hard about how can we make a seamless product, and that's the basis of the care program, which stands for Comprehensive Assessment, Risk, and Education. Given we're talking to the American College of Gastroenterology, my slide's not advancing, hold on. There we go. Given we're talking to the American College of Gastroenterology, I thought it was important to highlight how the ACG really does value taking a family history for every patient that actually is evaluated in an outpatient gastroenterology and endoscopy practice. Furthermore, genetic testing is really critical. And one of the reasons it's really critical is because clearly we might identify cancer patients, but it's really the only way of distinguishing patients who have a family history of cancer, specifically colon cancer in general, from those with hereditary mutations like Lynch syndrome. But if we just focus on colon cancer or GI polyps, we'll miss a number of cancers. As shown on the right, 20% of young colon cancer patients with a hereditary mutation have no family history of the disease. So the idea is that we can't just focus, as Heather mentioned earlier, on just GI-related conditions when collecting personal and family history. The other thing about this is once we identify a mutation in a family, so we find somebody who has a hereditary mutation, we can distinguish with additional genetic testing called cascade testing, individuals who fall in the general population from those who have hereditary disease mutations. So it's very powerful in distinguishing all three different groups in this setting. And so the way that we do that is using the National Comprehensive Cancer Network guidelines, which includes GI cancers, but as Heather mentioned, breast, ovarian, pancreas, and other types of cancers. So we look at this more on a global level of taking a detailed personal family history, assessing patients for the various guidelines that are out there, not just GI-related conditions, and taking appropriate steps to manage those patients using consensus guidelines. So now I'd like to introduce you to the care program. This slide will mainly focus on the high-level aspects of the care program. Clearly, identifying patients is the first step in this process, and we use NCCN guidelines. They're updated routinely to take the burden off of you of having to get those 5 to 10 updates a year that may occur from the NCCN guidelines. As Heather mentioned, maybe the GI guidelines only get updated once or twice a year, but when you think about HBOC and the other cancer guidelines that are out there, you may end up with 5 to 10 updates each and every year from NCCN. Now, identifying patients is only one aspect of this process. If you identify the patients, but don't make the process simple for patients and providers, then the patients may not get the testing that they need. So we really try to think about a seamless way to streamline this process for patients and providers. From a patient standpoint, we communicate them using a virtual assistant, which I'll describe more in detail in just a bit. That allows patients to complete a risk assessment based on NCCN prior to them ever getting into an appointment at your clinic. So we can assess the risks, we can actually determine whether or not they meet NCCN, and we can also educate them prior to them ever showing up to your clinic or through a telemedicine appointment as well, through GI on Demand, for example. That actually streamlines the process for providers, because providers are no longer having to hand out maybe a paper test or a paper questionnaire, or they're not having to spend as much time educating their patients on genes and hereditary if they do have that in their practice. We've developed strategies for doing both of those prior to them ever getting to their appointment. We've also saved time for those providers by making the care program integrate seamlessly into their existing workflow. And from a high level, if you're able to identify, you're able to simplify the process for patients and providers, offer testing in a streamlined way, integrate seamlessly into an existing workflow, the patients will get the testing they need and hopefully impactful results, which then may lead to personalized screening, therapeutics, and or preventative procedures. That clearly has a benefit to patients and their family members, but it also may benefit your practice as well. If we're identifying patients at high risk, such as Lynch Syndrome, instead of that patient getting a colonoscopy every 10 years, they may be getting every 1 to 2 years. So there's an additional revenue stream that comes from identifying patients as well. Now, the care program, as Heather had mentioned earlier, is an end-to-end solution. I'll go through each one of the pieces. I mentioned previously that identification is one of the critical aspects of it. That happens through our virtual assistant. The virtual assistant reaches out to the patient through text or email, is able to collect the personal and family history, and then instantaneously determine whether or not a patient meets NCCN guidelines, and then educates them prior to them ever getting into that appointment. One of the key aspects of identification is that you're not just selecting which patients are screened. You're offering it to a larger population, typically everybody who's coming into a clinic. So you're not just focusing on those cancer patients, you're also moving the genetics upstream to those who are unaffected as well. And therefore, you can really focus attention on prevention in those individuals. Once those patients have been identified and educated, they'd show up for an appointment. We made the process for testing really simple. We use a provider portal. I'm not going to go through the provider portal today just for a time perspective, but the provider portal gives access to all the patients that are coming into any given clinic, everybody who's been evaluated, determined to be meeting NCCN guidelines, could have testing ordered as simple as clicking an order button. The reason why it's so simple is because we've taken all of the information that's collected from the virtual assistant in the identification phase and pre-populated a test request form so that all the information is there at your fingertips. So you don't have to worry about spending time filling out a 1 or 2 or 3 page paper or online test request form. The process is much simpler. Now, identification, pre-test education, and testing is really critical. But one of the major aspects and barriers to many clinics is results delivery. Maybe you're a provider that feels like I could manage a patient who had Lynch syndrome, but I'm not exactly sure what would happen if I found somebody with Cowden syndrome or maybe a BRCA mutation. And through the care program, we were able to manage all of those different types of patients because multigene panel testing is a really important type of test that's offered to patients at this time. It's much more broad range, so you might get conditions that aren't specific to GI. Now, results delivery also happens through our virtual assistant. Negative and VUS patients can have results disclosed directly to them through the virtual assistant, but they still get offered genetic counseling after that results disclosure. Whereas positives are all required to receive post-test genetic counseling. Now, many patients have barriers about going to see a genetic counselor. Could be cost, could be time, it could be scheduling 2 or 3 months out. That occurs both pre and post-test. Could be uncertainty about the importance of genetic counseling. And that's really why we built the post-test genetic counseling piece to make it seamless for patients. They can then just take their phone, select a date and time that they want the genetic counseling appointment. Typically they'll have an appointment available in 1 or 2 days. They no longer have to travel. It can be done through telemedicine. So we reduce the number of the barriers that patients face in getting the genetic counseling they need. We've also required it for positives, but only offered it to negatives and VUS. That way that patients can make the determination whether or not they have additional questions after getting education from the virtual assistant. And lastly, another important aspects of any type of program is the documentation about all of these different steps. It's an end-to-end solution. You don't want to just document one aspect of it. We have a clinic summary that's created from the identification piece and the education. In the care provider portal, we have the testing that was selected in addition to the results. If post-test genetic counseling is required or requested by the patient, that's documented in the provider portal, and the post-test genetic counseling note is integrated into the system as well. Therefore, if you have a patient with Lynch syndrome, you'll be made aware whether or not that patient needs to have a colonoscopy every 1 to 2 years. If you have a patient with a BRCA 1 or 2 mutation, the genetic counselor will determine what the recommendations are for them and then outline a plan for them to follow up with a breast surgeon, getting a breast mammogram or an MRI, all those other things that you may not want to manage in your own GI practice. So a little bit more about the virtual assistant. The virtual assistant is called Ava, Ambry's virtual assistant. I mentioned before that identification is a critical component, but also the way we introduce the program is also very important. And we actually email or text patients an invitation to complete a risk assessment questionnaire. We customize this per clinic. So we could say that we're working with GI on demand, or we're working with this healthcare clinic, and your doctor has asked you to complete a risk assessment questionnaire, and then they'll end up saying, click to start. They'll be provided with a secure login to the patient portal. They'll then be able to complete their personal and family history collection. And then if they're determined to meet NCCN guidelines, they'll be educated on some of the basic elements of informed consent. So Heather and I are actually both genetic counselors. We cover a lot of the same things in pre-test genetic counseling appointments, things like what are genes, what's hereditary, what's the cost of genetic testing, what is genetic discrimination. So those are some of the basic elements of informed consent that we cover in the pre-test education, but we do so in a way that's very patient-centric. And what I mean by that is not all patients learn the same way. Some patients may learn better via text. Some may learn better via videos or images, and all of those are included in the pre-test education, additionally in the post-test education as well for negatives and VUSs. Patients can also select to learn more information at their own leisure. So if they understand what a gene is very well, maybe they'll pass by. They won't ask about additional questions about genes, but they have more questions about genetics, more so than what we've explained to them. They can ask additional questions or proceed with additional information in the pre-test educational module. So they'll be able to self-select what additional information they need in order to make an informed decision once they get to your clinic or through a GI on demand platform to determine if they need genetic testing. So a little bit more about Ava at work. It's HIPAA compliant. Clearly, I'm sure everybody understands the necessity of HIPAA compliance, but SOC compliance is actually an additional level of security that many clinics and hospital systems may require overall. And so our virtual assistant, our provider portal, and our patient portal are all HIPAA and SOC compliant. Ava is able to collect information for personal assessment, Ava is also able to identify patients who will benefit from genetic testing, also able to deliver genetics education to patients. And as I mentioned before, Ava can assist in scheduling genetic counseling appointments. I'm sure most of you have some familiarity with what a genetic counselor does, but on the post-test genetic counseling and documentation side, just some of the key highlights. Genetic counselors will discuss the implications for management, including NCCN guidelines, consideration of medical, economic, and psychosocial factors. Once we identify a positive mutation, it clearly has ramifications to the family members. So they'll cover the discussion of cascade testing and the importance for their relatives. And then lastly, documentation in a genetic counseling note is really key. Therefore, you get the information that you need, the patients get the information that they need so that they can actually be empowered to take control over their healthcare and be provided with options and recommendations on what to do next. So just in my last couple of slides, why Ambry's care program? Well, we're really trying to empower patients by giving them the opportunity to have information about genes and get genetic testing. Now, not every patient is going to want this information, but most patients right now are not being provided with this opportunity to get this information. And even if they are being provided with some opportunity to get this information, patients have a lot of barriers to getting that genetic testing. So we're reducing those barriers and giving patients the opportunity to get it in a way that they haven't been able to get it in the past. The care program really is based on quality guidelines. That's for both the genetic testing piece with NCCN, but it's also post-test with the genetic counseling recommendations that are based on NCCN consensus management guidelines. Ultimately, the care program is targeting both unaffected and patients with cancer. A lot of clinics that do actually identify patients that meet genetic testing criteria may only focus on those with cancer, maybe only those with colon cancer, for example. But we are really trying to screen a larger population overall, including those that are unaffected. And what that gives us the opportunity to do is focus precision medicine on prevention. So we're able to make sure that patients are getting their colonoscopy and they don't get those colon cancers. And this is just one example, but clearly one of the outcomes that matters is that we can identify somebody with Lynch syndrome who has a high risk of colon cancer, need to be managed more frequently with colonoscopies. We can reduce their cancer risk. And even if they do get cancer diagnosis, we can increase their survival. So I appreciate everybody's time. We'll have we'll have some time for questions at the end. I will pass it back off to Jordan just for a couple of next steps, and then we'll transition over to some remaining questions. Thank you, everybody.
Great, thanks. So in terms of next steps, we are conducting some pilot studies right now. Hopefully these will be done quickly, but if you are interested in being a pilot site, please email at pilot@giondemand.com. And you could join the waiting list to launch your clinic after the pilots by visiting giondemand.com. And I guess kind of to conclude before we take questions, I guess I would say that these patients are out there. They're in our practices already. And for the most part, we're unaware that we're even interacting with them on a daily level. So I think we all have to understand that we are already seeing these patients already, but they have not been risk stratified by genetic testing. And obviously that puts them and their family members at risk. So I think that's a good closing remark for the importance of integrating genomics into GI practices.
I agree, Jordan. That's a great point. And I will say, even as a trained cancer genetic counselor, sometimes I'll be testing a family for one condition, and if I order a panel, I will even get surprised by finding a second condition in the family, perhaps coming from the other side of the family that was not obvious. And so I think the more that we've done these multi-gene panel tests, the more humble we've all become, because it's very hard sometimes to identify these individuals based on family history alone. And it's so important because it can absolutely change their management. So we are taking questions now. Please submit questions to the question tab, and I'm going to go ahead and get started by asking a few of them. One of the ones we have a few for Kory, first of all. So Kory, one thing I wanted to point out, If a patient does test positive and get the Televideo genetic counseling, or even if they're negative or have a variant of uncertain significance and elect to have the Televideo genetic counseling, is there any additional charge for that to the patients?
Yeah, really good question. So one of the barriers as it relates to patients is cost. That actually is both from the genetic testing aspect and the genetic counseling. So when it comes to genetic testing, and I know that wasn't the specific question, but it's an important piece. In this program, 80% of patients who have genetic testing pay zero out of pocket for the test. The remaining 20%.
Kory, is that because you pre-screen? Is that because you pre-screen them so well and you know they meet NCCN criteria?
Correct. And so we're really targeting patients who need the test the most, which are the NCCN-based criteria, although there is an opportunity to test patients even who don't necessarily meet NCCN for whatever reason there are. But the vast majority of patients meet NCCN, and therefore we expect that over 80% or over of patients will pay $0 for the test, and then the remaining 20% pay less than $100 out of pocket for the genetic test. Now, when it comes to the genetic counseling question, genetic counseling is included at no additional charge for this program. We knew that that was one of the barriers for many patients, whether it was concern about the cost of genetic counseling or the actual cost of genetic counseling. Either way, we educate patients that there is no cost to schedule a genetic counseling appointment for negative VUS or positive patients.
That's really great, Kory. So the only bill at all would be for the genetic testing, and because you pre-screen these patients to find that they meet NCCN criteria, it sounds like most of the patients aren't even going to have any balance bill at all, or if they do, it will be quite low. So that's an important point for access. We had a question.
And we have financial assistance programs as well. So there's additional pieces that are available for patients as well. So
that's great. Somebody asked, do we do other genetic tests through the program? So I should probably take this opportunity to explain that we've chosen a pre-curated panel for our GI on-demand collaborators that includes all of the common hereditary cancer genes and even some preliminary evidence colorectal polyposis or colorectal cancer genes. So we've got this as kind of our default panel, but one of our pilot clinics actually asked us on a call 2 weeks ago, what about the hereditary chronic pancreatitis genes? And that is, of course, a panel that is available at Ambry. And if that's something that your practice sees a lot of, we think that we can work that into the test order as well. And so those are kind of where we're starting with the GI offerings. We don't do, for example, HLA testing for the permissive haplotype for celiac. That's not the same. These are autosomal dominant, highly penetrant cancer susceptibility genes or chronic pancreatitis genes that are done through this laboratory. But we're really excited that it's a very thorough panel that includes all of the common hereditary cancer genes and all of the new polyposis genes. So you don't have to hand pick them. They are pre-curated for you. Jordan,
go
ahead. I have a question for you too, but go ahead, please.
No, I was just going to kind of chime in and talk about some of the stress, I guess, over the years in terms of ordering genetic testing for GI providers was deciding which tests, which combination of genetic tests that you would need to order. And I think this kind of takes that out of the equation because it's one standardized panel that kind of includes everything that needs to be evaluated. And I should also point out that, the way that this platform was designed really was to kind of take the complexity away from the GI providers. So some GI providers may have an interest in genetics, but many don't. And what this does is it really allows the provider to be as close to the process or as far away from the process as they want. Obviously, they're going to get the results back, but you're not going to be alone in your interpretation because there's clearly genetic counselors that are really going to be doing the heavy lifting in terms of explaining the results to the patients and relaying to you what you need to do in terms of managing these patients.
And Jordan, that really dovetails onto this next question really well. And this was a comment that the average GI doc doesn't really know what to do with all of the results from a genetic test. And that might be the reason why it's not getting ordered as often. So, I know variants of uncertain significance, nobody likes them, not even the genetic counselors. But do you think that having, kind of this setup where you have the support from the lab and the lab genetic counselors would be helpful in that regard?
Yeah, I think that's going to be critical, and that was one of the main factors that came up in that clinical and translational gastro survey study just from a few years back. Was difficulty interpreting results was actually a barrier to people ordering testing. So I think by kind of taking that out of the equation and making sure that there are adequate resources for test interpretation is really, really key. And in addition, as I mentioned before, not having to choose which test needs to be ordered. Basically, all this stuff is being done for you, and the patients are getting direct communication with regards to the results. So I think this is really going to streamline things and really take a lot of stress away from the GI providers. And the way things are moving nowadays, genetics are an absolute necessity, particularly for GI oncology. And it's just a movement that I think we all need to start getting more acquainted with.
And Kory, someone asked if they have to handle the genetic test ordering in their practice, or would there be maybe another option if they weren't comfortable with doing the ordering themselves?
Yeah, in the pilot sites, it's likely that the sites themselves will be doing the ordering. Once again, it is a very simple process. As you and Jordan have mentioned, the idea is that we're using multigene panel testing, so it's no longer the case. Should I include Lynch syndrome and APC? Should I just include APC or just Lynch? I mean, what we're really able to do is not have to worry as much about what genes we're selecting and do a multigene panel test, so that is an easier process. We also include options for sending a saliva kit home to a patient, so if they weren't able to get that sample collected in the office, that saliva sample could be sent to the patient's home, and then the patient could collect it and then send it into the lab directly. So we make some easier options, once again, making things streamlined and efficient for both the patient and the provider. In the future, after launch, we likely will have the option of having a third-party independent physician order the test as well on all patients that are within the practice. And so we'll have more information after the pilot sites in general, so that sites will be able to choose which one they elect to proceed with. And there's benefits and positives for both of those.
That's great. Yeah. So for the pilot, you'd be ordering the test yourself, but again, it's just a couple clicks and the patient's already been pre-screened and pre-educated with the informed consent. But once we roll out to everyone, which we're anticipating will be in June, you will have the option of having someone else order the actual test for you. You still, again, would be involved in the whole process and getting those results back, but it would take away that portion. I think, Kory, that's a good point about the saliva kits. One of the things that Ambry does is really visit your clinic before you go live and assess your flow and your pressure points in the clinic. And, if drawing blood on everyone would, slow down the clinic too much, this option of having the saliva kit sent to their home is great. That's actually how I've done all my cancer genetic counseling for the past year due to COVID, because I've been doing all my appointments by Televideo. So I just have saliva kits sent to the patient's home, and they're quite easy for the patients to do at home at their convenience. They don't have an exposure also during a pandemic, which is nice for them. And they just drop it in their mailbox, and everything gets taken care of from there. So that's great. Kory, one person asked if a patient needs to have a smartphone to be able to participate in the care program.
Yeah, really good question. The answer is no. So they can use their computer, they can use a tablet, but additionally, what that really helps out with is helps to collect information prior to them ever getting to an appointment. But that doesn't happen in all cases. And so we are able to implement tablet-based devices into the clinic, and we provide those tablets. Additionally, what we have found, because this is a common concern people have, I have a lot of 70-year-olds in my clinic or whatever the case is, we see across age groups really good participation in this program. Some of our clinics have over a 90% completion rate. So that was almost 5,000 patients the assessment was sent out to. They had almost over a 90% completion rate, and most of those were prior to the appointment. And I can tell you that clinic is not a pediatric clinic. It's a clinic with adults of all ages.
Wow.
And so people will get their family members to help out They could end up at the actual appointment and ask for additional help from a clinic staff member or use a tablet. There's multiple ways to get good patient engagement, and I'm not saying that everybody can expect over a 90% completion rate, but if you think about it, if you sent a questionnaire out to your patients in any format, whether that was a paper TRF, whether it was electronic, whether it was collecting information over the phone, you're probably not going to expect over a 90% completion rate in general. And so we have really good interactions and engagement with patients. We try to make it not so fearful for them. We try to make sure that their doctor's on board with this strategy, the importance of completing this information prior to the appointment. We take a lot of pride in making sure that patients feel comfortable with this program. It's secure for them. It's at the advice of their physician who's helping out with this program. So I think that's why we have good engagement.
So we're running out of time, and now we've got great questions pouring in. We will try to get through a few more. If we don't get through them on live tonight, we will email you back separately and get the word out. But I'm going to try and handle a couple of them quickly. We had a great question. How are we going to handle cascade testing or perform a handoff to a local GC? So say your patient tests positive, they get genetic counseling from the Televideo genetic counseling service that Ambry is affiliated with. That genetic counseling service will provide the information for those relatives to make local or Televideo genetic counseling appointments, and will help get them steered in the right direction. We can also make sure, if you don't have them already, that you have contact information for your local genetic counselors who can take over the cascade testing in the family for you. So that is a great question. Kory, anything to add there?
Nope, you covered it.
Okay. All right. What is the cost of integrating this into your GI practice? This is a great one. There is no cost to the GI practice for integrating this. So please just contact us if you are interested. I don't know if it looks like we're accepting a few more sites into the pilot, and then after the pilot ends in June, any site that wants to participate can participate. And it really just takes some commitment and time on your practice's part to make this a part of the care that you're offering to your patients. We've got a similar question was kind of how do we refer patients, or what online tool are we suggesting people use? The online tool I showed during the talk was called PREM5. You can just Google that and you can run through that with a patient, but that only predicts their likelihood for having Lynch syndrome. So if you want a more full-scale risk assessment, you would need something like this CARE program integrated, or you can manually use the NCCN criteria to assess family histories. Broadly available to community practices in June. So if you want to participate, let us know. Sorry, there's a whole bunch. Can we back up to the slide that showed people how to become a pilot site or to join? Kory, okay, perfect. And there was a question about the porphyrias. No plan to add them right now, but if we get a lot of inquiries from our GI practices, we can talk about it. Kory, do you guys have the porphyria genes?
Not included in our current practice.
Okay, but do you have them as a panel just in general? I'm just curious.
No.
Okay, so that would be handled separately, not through CARE, which is focused really on cancers and polyps. We had a specific question about a teenager with more than 20 polyps and negative gene testing. I always tell my polyp patients that test negative that we won't have enough new genes in 1 year to repeat their testing, but in 5 we might. I would certainly follow them as polyposis of unknown etiology for now, and consider repeating testing in 5 years. The other thing that's been done with these patients is they've found somatic mosaicism in some of them, and you can actually test a couple of their polyps. I mean, if you find, for example, the same APC mutation in more than one polyp, that could be a sign of somatic mosaicism. That's pretty complicated. You may want to work with a local genetic counselor on that case. Okay, so I think I'm just scrolling through to make sure we got everything. Why don't we just go through? Jordan, do you have any last comments?
So I know that someone asked, and I just want to make sure that we answer this, whether or not there's an option if the GI doctor does not want to order or the GI provider does not want to order the testing themselves.
Yes. So there isn't during the pilot, but there will be when we go live in June.
All right. So that's going to be an important option. So
Yeah,
if
definitely.
the provider's kind of reluctant to do it, there is going to be a way where
even
that can
too
be
busy.
bypassed.
Yeah. That'll be great. And Kory, any last comments from you?
Oh, I think we covered them all.
Okay, well, we want to thank everyone for being here this late. I know you've all had a long day already on this Lynch Syndrome Awareness Day. I think we were well over 130 at one point. We appreciate it. For those of you who are interested, on the screen is how to email if your site would like to participate. Thanks very much.
Thank you, everybody.